My lecture is about the MAUDSLEY prescribing guidelines in Parkinson's disease. This was taken from the latest version, which is 2012, the 11th edition. And there is actually no difference between the two editions, except in a few details, which I will tell you later. The outlines, it will be introduction, depression in Parkinson's disease, psychosis in Parkinson's disease, and dementia in Parkinson's disease. As all of you know that Parkinson's disease is a progressive degenerative neurological disorder characterized by resting tremor, cogwheel rigidity, bradykinesia, and posture instability. And the prevalence of comorbid psychiatric disorder is high. Many patients with Parkinson's disease would have neurologic psychiatric illness. 50% will have major depressive disorder, ranging from full-blown MDD to mild version of major depressive disorder during the course of their illness. 25% would have some sort of disorder from anxiety spectrum disorder, and 25% will suffer from psychosis, and the majority, up to 80%, would develop dementia later on in their courses. Recommendation for treatment of depression in Parkinson's disease step intervention, as published by the MAUDSLEY guidelines. First is to exclude or treat organic causes such as hypothyroidism, which have higher prevalence in Parkinson's disease. SSRIs are considered to be first-line treatment. Some patients may experience a worsening of motor symptoms, although the absolute risk is low. Care must be taken when combining SSRIs with selegiline, as the risk of serotonin syndrome is increased. So always look for signs of serotonin syndrome when you do this combination. Tricyclic antidepressants are generally poorly tolerated because of their anticholinergic, which can worsen the cognitive problems and cause constipation, and the alpha blocking effects of it can worsen even the autonomic dysfunction in those patients. Many randomized controlled trials have shown low-dose amitriptyline to be more effective than fluoxetine, and low-dose amitriptyline and sertraline to be equally effective. In the older version, in the 10th edition, they add that a questionable effect about paroxetine. Some would say it is beneficial, some would say it's not. But in this version, they deleted this sentence and they added that atomoxetine is not effective in treating depression in Parkinson's disease. The third step from this algorithm is to consider augmentation with dopamine agonist releasers such as pramiprexole, and which may increase the risk of impulse control disorders and even psychosis. Consider ECT, depressions, and motor symptoms generally respond well, but the risk of inducing delirium is high, particularly in patients with pre-existing cognitive impairment. And if these all measures failed, you follow the algorithm of treatment of resistant depressions. You know, the old one is either to switch, combine from different classes. Psychosis in Parkinson's disease, often characterized by visual hallucination, auditory hallucination, and delusion, occur far less frequently and usually in younger patients. Psychosis and dementia frequently coexist, having one predict the development of the other. Sleep disorder is also a known risk factor for developing psychosis in Parkinson's disease. The majority of patients, psychotic symptoms are thought to be secondary to dopaminergic medication rather than the part of Parkinson's disease itself, because they are taking levodopa, and it is a risk factor even to develop psychosis to anyone who, even without the process of the disease itself. Psychosis is the major contributor to caregiver distress and the risk of factor, and is a very known risk factor for institutionalizations and early death. Recommendation for treatment of psychosis in Parkinson's disease step intervention. Started with exclude organic causes such as delirium. Optimize the environment to maximize orientations and minimize problems due to poor caregiver-patient interaction. If the patient has insight and hallucination are infrequent and not troubling and not bothering him, do not touch, do not treat. Consider reducing or stopping anticholinergic and dopamine agonists. Monitor for signs of motor deterioration. Be prepared to restart or increase the dose of these drugs again to achieve the best balance between psychosis and mobility. Try an atypical antipsychotic. The efficacy of clozapine is supported by 2 placebo-controlled randomized controlled trials. Low dose of quetiapine is the best tolerated, although ABS and stereotypical movement can occur. It is therefore reasonable to try quetiapine before clozapine, but the success rate may be low. So clozapine is effective, but because of its risk of aplastic anemia, that's why this recommendation was in favor of quetiapine. Olanzapine, ripiprazole, and ziprasidone probably all have greater adverse effects. There were no study to confirm it, but it was being advised to avoid it in motor dysfunction than quetiapine. Risperidone and typical antipsychotic should be avoided completely. Severe rebound psychosis has been described when antipsychotic drugs, quetiapine or clozapine, are discontinued. Recommendation for treatment of psychosis in Parkinson's disease: note that all antipsychotic may be even less effective in managing psychotic symptoms in patients with dementia, and such patients may be more prone to develop motor and cognitive side effects. Antipsychotics have been associated with an increased risk of vascular events in the elderly. Consider cholinesterase inhibitors, particularly if the patient has comorbid dementia. Try clozapine start at 7.25 milligram, which is quarter of the usual dose, which is 25 milligram. As for schizophrenia, the elderly are more prone to develop serious blood dyscrasia. A case of aplastic anemia has been reported. You will follow the same regimes of treating clozapine in schizophrenia, but you start low and you go slow. Consider ECT. Psychotic and motor symptoms usually respond well, but the risk of inducing delirium is high, particularly in patients with pre-existing cognitive impairment. Dementia in Parkinson's disease. Cholinesterase inhibitors, as all of you know, would improve cognition and delusions and hallucination in patients with Lewy body dementia, which has similarity to Parkinson's disease. There were no clear studies done with using cholinesterase inhibitors in patients with dementia and Parkinson's disease, but they compared the 2 studies that Lewy body dementia, as all of you know, has a triad of dementia, bradykinesia, and visual hallucination, have similarity to the presentation of dementia and Parkinson's disease. And it showed that using cholinesterase inhibitor with them has a modest improvement. Motor function may deteriorate. Improvement in cognitive functioning are modest. Dementia and Parkinson's disease, there were one study which is supporting, as I told you before, dementia of Lewy body rather than dementia and Parkinson's disease. A Cochrane reviewer concluded that there was most evidence for rivastigmine. 15% of patients experience clinically meaningful improvement in cognition and activities of daily living. Thank you.